on advisory board for the UK government during the COVID crisis. So he's going to here to relate to us sort of his experience as an expert advising the government in a crisis we've discussed quite often, and sort of tell us how it went, and we'll then pick his brain about it. Okay, floor is yours, Aditya. I will mute myself.
First
do you want to share your screen? Do you have slides you want to share?
I'm going to share my screen.
Okay.
And let me just start with a slideshow. First of all, thank you, David, for inviting me to give this talk. It's been about 2 years, just coming to an anniversary of 2 years since I started working with the UK government on COVID policy. So it's given me a chance to look back and take stock and think about what role economists have played, could play, etc. So I must make a disclaimer. This is my private views. These are not represent that of the UK government or the committee that I've been working with. So when we think of the COVID-19 crisis, it starts off as a public health crisis. And given the magnitude of infections and mortality, immediately it becomes an economic crisis as well. To me, it is not surprising that this public health crisis would turn into an economic crisis, because that is the experience we have seen with other pandemics going back hundreds of years. In most countries during the COVID crisis, the response was driven by public health considerations. And there are two aspects of COVID policy. One is the economic response, which is what central banks and the fiscal measures. These, as we'd expect, economists have been very heavily involved with. And I'm going to talk very little about this aspect. I'll talk more about the role of economists in the public health space, which is thinking about how policies for non-pharmaceutical interventions such as mask wearing, social distancing, border controls, lockdowns, etc. What is my understanding of this role and my experience of this role? So I'll concentrate my talk based on my experience in terms of what happened in UK. And I should say what happened in England, because what was happening in UK starts off by being a unified policy, but then over time, Scotland and Wales start doing their different things. But I'll call it UK policy. So if we now think about who are the main players in this policy space, one is number 10, the Prime Minister's office. The Treasury, which is doing its fiscal measures, and the Bank of England. Now, traditionally, the Treasury and the Prime Minister's office, number 10 and number 11, these two have had a complicated role in terms of not always has the Prime Minister been able to tell the Treasury what exactly to do. This is going back a long time. So what I'm going to concentrate on is what is my understanding of what was happening in number 10 and the Prime Minister's office, which was making the decisions on lockdowns and non-pharmaceutical interventions. The Treasury was doing its own thing in terms of fiscal measures. They sit in the cabinet and their colleagues. Eventually, the head of the finance minister reports to the prime minister, and eventually that is how policy was being made. But I'm not going to talk a lot about the fiscal measures. And the Bank of England in UK is independent, so it is doing its own thing in terms of setting monetary policy. Now let's try and understand the landscape of what is going around the Prime Minister's office. I should say, if you have any questions, please interrupt and ask. It's easier to explain as I go along. So we have the Prime Minister's office in the middle, and then we have different groups. So on the right of the group in blue are the pressure groups, the right-wing press, backbenchers, and party donors and VIPs. Certainly, the Prime Minister, what the press is saying and what the backbenchers are saying. And there were two influential groups. One was the European Research Group, which was there in terms of the Brexit. But some of the people also became part of the COVID recovery group, which had its own agenda in terms of what should be policy. And these two, the right-wing press and the backbenchers, act as pressure groups on the Prime Minister's office, as I understand it. Similarly, party donors and VIPs, the VIPs became controversial in the UK's situation, because once contracts were being given, things like getting PPE equipment, there was fast track for VIPs. So these on the right are the pressure groups. On the top is the cabinet and the SPADs. So the cabinet, clearly people in the cabinet had difference of opinion on terms of what exactly should be the policy. There were people, as far as I understand, Rishi Sunak, who's the Chancellor of the Exchequer, who wanted a much lighter touch in terms of control. The current Health Secretary, Sajid Javid, also wanted a much lighter control, but he was not in the cabinet at the initial stages. And then you have the SPADs, which are special political advisors. These are not civil servants. They're appointed by the Prime Minister, and eventually the Prime Minister wants people who are the advisors to them, and eventually the Prime Minister wants people who he or she trusts and bounces of ideas. And they were quite influential they are quite influential in policies setting in UK. The one who has been in the press, Dominic Cummings, if you follow the British news, and another one who's been in the press for other issues, and Munira Mirza. So then you have these political advisors. On the left-hand side in orange, we have these appointed groups who are advisory groups to the Prime Minister's office. They give advice which the Prime Minister feels is necessary to set policies. The one on top is SAGE, which is the Scientific Advisory Group on Emergencies. It was always there, but in the times of COVID, it became very important. SAGE is largely currently composed of people in health, public health, epidemiologists, etc. There's subgroups of SAGE, and one subgroup which may have been where economists could have played a role is the behavioral group called SPI-B, but as you know, no economist sits on SPI-B. So the SAGE and its subgroups are either scientists, if I may use it in inverted commas, not social scientists by and large, people in other chief scientific officers, public health officials, etc. The one below is JCVI. This is a commission which advises on vaccination policies. So it was tasked with coming up with the vaccination policy in terms of who gets vaccinated, when do they get vaccinated, etc. There is going to be some interaction between the groups, but JCVI was a group which was tasked with coming up with the policy in terms of vaccinations. NERVTAG is another group which is on new and emerging respiratory and viral Diseases Advisory Group. So it also played a role in terms of policy setting. But I think so SAGE and JCVI were the two groups which were perhaps most influential. Now we come to the last one. This is the International, I've got it wrong, Best Practice Advisory Group, IBPAG. That's the one I wasn't a part of. So this was a group set up by Cabinet Office and the Foreign Commonwealth Office to give advice to, I'll talk a bit more about it in more detail. This is an interdisciplinary group. So it comprised of people in policy, in health, some social scientists. I was an economist on that group. There were a couple of health economists, someone from the finance industry. So this is the most interdisciplinary group. The top three are largely people from what we call the physical and medical sciences. And then on the bottom, these two gray ones, we have the civil service, who is largely non-political. They're required to be non-political because if you have seen the old shows of Yes Minister or Yes Prime Minister as well, they give you a good idea that you have the civil service, which is, it is there to serve whoever the political masters are. They are very professional in the work. And actually working with them, my impression of them improved, went up dramatically, their professionalism. Now, in terms of civil services, it's a big civil service. So there was a COVID task force, which was, focusing the attention on COVID. And we had people, effectively, the group I was with, this last group, was set up effectively by that COVID task force. And then you have on the public health system, Public Health England, which has now been disbanded by a new, replaced by a new organization. And then you have the NHS. So the bulk of the work is being done by these gray groups. We have some pressure groups, the blue groups, and then you have these advisory groups, which are these orange groups. The thing which I want to say in terms of role of economists in these groups, say JCVI and NERVTAG, there are no economists. The only place where they show up is in this group. Any questions?
Sounds good so far.
Okay, so this is in terms of the start of the pandemic. The first lockdown takes place in Wuhan in January 23. Italy is one of the first movers because it's also the first country in Europe which is hit severely by the pandemic. UK has a very lagged response. Clearly, the pandemic was there. It was clear it was going to spread, but UK acts very late. Now, this is a timeline in terms of what is going on in the different interventions.
Aditya, this one is very difficult, at least for me to read.
No, I know it's very difficult. So I'm just going to, I just want to highlight that there's a lot of stuff that is going on, right? The first lockdown takes place in March. This is, it's eased off in May. The second lockdown takes place, this is a second lockdown. This is the end of the second lockdown. The second lockdown is in here, September. Yes, September. It's eased off in December. And then there's a third lockdown in 2021. I got involved in policymaking in May. This is towards the end of the first lockdown. So the first lockdown, what went into the first lockdown, I don't have a lot of insight, but in some of the subsequent developments, we were seeing some of the papers which were going to number 10, giving advice on thinking about different aspects. Now, this is the group I was part of, this International Best Practice Advisory Group. Now, what is the group trying to do? It was set up by the Cabinet Office and the Foreign Commonwealth Development Office. And this group is basically saying, what are other countries doing? So the British government was thinking, what is the scientific advice, which is coming largely from SAGE, but it's also thinking about what are the best practices of other countries, as well as things which other countries are doing, which we should not be doing. So this advisory group was set up to give advice on insight on what is happening in other countries. That's why it's called International Best Practice Advisory Group. So it's multidisciplinary, experts in a variety of areas, health, public policy, science, and economics are in it. It also includes chief scientific officers of different government departments. So the key thing is that most of the people in it are not civil servants. They are academic experts, some of them working for the government. And as I'll make clear, most of us are not working for the government, we're just their experts. As the meetings went, there was a core group which attended most meetings, but 7 or 8 of us which attended most of the meetings. The list, which you can see on the internet, is quite large, but some people attended some of the meetings, not all of them. We started weekly meetings in May 2020. We would meet every Tuesday afternoon so as not to clash with the SAGE meetings. There was some interaction between what SAGE is saying and what this group is saying. There were observers who would act as a go-between between these two groups. Some people from my group, the people who were chairing it, would sit on the SAGE meetings. I don't think any of us in this group, the core members were on SAGE. They were in some of the subgroups of SAGE, but not in the main SAGE itself. So this is what the remit is. It's to help assess responses to the pandemic, inform policymaking to the government, and our role was to, this is where it's defined, improving quantitative analytics, clarifying technical concepts of processes, making a recommendation on how to enhance quality of analysis, and suggest ways of monitoring, forecasting, etc. So,
can I intervene just briefly at this point? So this is not international best practices in terms of whether to lock down or make people wear masks. This is best practice in terms of analyzing data, it sounds like. Is that correct?
No, not necessarily.
Okay.
It was also, I mean, let's take the question of masks, for example. So there was a question, what is the evidence, scientific evidence for efficacy of masks? So SAGE would have its views, but the government would want its own views. So it would ask civil servants, for example, to look at the evidence. And then we had experts, and we would think about what exactly is the evidence on mask wearing. NERV-TAG would also give its input, but the government wants a variety of inputs because the scientific experts will look at the scientific literature, but there may be evidence which is there in other countries in terms of public health policies in other countries. So for example, the Asian countries started wearing masks very early on. They have a history of wearing masks, starting from at least the SARS epidemic, and wearing masks to deal with pollution. So we would want to know whether we have other evidence other than what's there in the published literature on efficacy of wearing masks.
Thanks.
And we'd also want to know that, as time evolves, what are the different countries doing in terms of having policies for wearing masks?
Okay, thanks. No, that clarifies that.
Yeah. So the way it would work is that, there would be what is called analytic product, which would be commissioned. And then we would meet weekly to provide expert advice to improve the analysis. So we would bring in what we knew, what was happening in other countries, what we knew of developments in the academic literature. We would be asked to think about what are the potential trends, potential problems, what are the developments in the academic literature, data sources, etc. We did not write the reports ourselves, but we contributed to taking the product and improving it so that it could go in, pretty tight, as this is the best way of thinking about a given problem. We looked at a variety of topics which could deal with epidemiology issues, thinking about what is going to happen in the future, economic issues. It could have dealt with unemployment, what is happening in terms of productivity from working from home, NPIs, future trends, etc. So we looked at a wide variety of
What are NPIs?
Non-pharmaceutical interventions. So wearing masks, social distancing, travel restrictions, lockdowns, etc. Yeah. I'm being a bit unspecific in terms of what exactly we looked at, because the minutes and papers are classified, as this is based on confidential sources. SAGE minutes and papers are there, NERVTAC papers are there, JCVI's recommendations are publicized, but what the group was doing, these are confidential documents. So I can be only a bit vague about the kind of issues we looked at and not go into the specific details of what are the issues we exactly looked at. So the way it worked is we use the Chatham House rules. Basically, we say things, but it's never said, A said this and B said that. It just says this was discussed. We are not remunerated. We allowed academic independence, so they wanted challenge. They want, and we're allowed to speak to the media. Unlike SAGE, SAGE members, except the head of SAGE, and the chief medical officers, the SAGE members were not allowed to speak to the press. We had people who were writing in the Guardian very prominently, so people were engaging with the media, and we were allowed to maintain academic independence. At times, we did have ad hoc consultation of other experts. We had economists a couple of times. So this is about what we did. Now, what is my understanding of other countries? Because we don't want to just look at the UK experience. My understanding is most countries in the Asia Pacific had the interventions driven purely by public health interventions. I don't know if any economists were engaged in these kind of policies. certainly they would be involved in fiscal and monetary measures, but not in the public health interventions, which is what we're focusing on. In Denmark, uh, it was largely a public health response, but there was an economic advisory group set up headed by Torben Andersen in conjunction with public health experts. Eventually, the public health response moved so fast in Denmark that it eventually, became the most important thing. Similarly, in Norway, there was a group which was commissioned by Directorate of Health, chaired by Steiner Holden. And one of the things that they really worried about is how to get a value of statistical life, in terms of, if you want to think about the economic costs, how do we value a life? Should we look at how to exactly measure the value of a statistical life? Sweden, as far as I know, was largely done by the public health agencies. And from what I've read, academics were not involved in policymaking, and certainly not economists. This is my understanding. In France, there is the Council of Advisors. I don't know how involved they were with policymaking. There is a Blanchard-Tirole report, but this was not on COVID policy per se, but on thinking about global challenges. Germany had a public health perspective relying on the Robert Koch Institute. Again, as far as I know, economists were not directly involved in the public health aspects. India, this country I follow, not clear if any advice was being followed. So we have the space of public health policy, which is being set. It has big interaction with economics. And from what we see, at least my understanding is that not many economists have been involved in this debate in terms of what policies to be set. What is something that economists would bring and perhaps was not brought because of lack of representation of economists in this space. Simple things like development of methods. Most people don't understand an Euler equation. So if we see current consumption going up, then the press and everyone is very excited that it's not affecting the economy that much. But we know from the Euler equation, current consumption goes up. It depends on your expectations of what's going to happen in the future. So even things of that are not very well understood by most policymakers. Differentiating with correlation causality, for us it seems very obvious, but a lot of people don't understand the distinction between the two. The fact that these interventions are endogenous, so often people track how important, how severe is intervention, but the intervention is responding to the severity of the pandemic. There are new methods of identification, which economists have become very good at in trying to tease out what is the data telling us about the effect of policies. And the understanding of institutions. So if you look at what is happening in Germany or what's happening in Japan, they have certain institutional constraints in terms of what the central government can require or mandate for the country. Similarly, for the US, there the national body can only make recommendation, and it's up to the county level to set policies. People in the other disciplines, the pure science disciplines, spend their time thinking of other problems and are not necessarily up to date in things which economists can bring to understand the effectiveness and the setting of policies, which has economic consequences. Clearly, in the British case, and I'm sure in most other countries, there was a clear debate on what is the trade off between health and wealth. So, if you're setting your policy based on health considerations and not fully understanding what is the impact on wealth, then the policy is going to be not set in the best possible way it could be set. I got involved because someone read my papers and said, okay, we should get him involved in this committee. Clearly, before the pandemic, there weren't many papers talking about or thinking about the interaction of infectious diseases and the economy. I'm putting a dynamic general equilibrium framework because that's what we really want to do. If you want to think about effect of public health policies in the case of infectious diseases on the economy. There is the work of Shankar Chakrabarty, who works in using overlapping generation model, and then the work of my work with my co-authors Lin Liu and Manon Nguyen, which we use a more standard neoclassical or endogenous growth model. We used epidemiology dynamics. Our interests were different when we started off working on these problems. And then COVID happened. And at least for me, I got involved in policy making. So what are the insights from the pre-COVID work? Yeah, I mean, there's a lot of work which has been done in economics at the time of COVID, and I'll talk about it after a few slides. But these are my insights, which I think so have largely proven to be consistent with the evidence. Firstly, that infections will affect activity even without having any lockdowns or quarantines. And the main driver is that the disease affects labor productivity, even if there's no mortality, even if people are dying in large numbers, as we are in this situation today in most of the European countries. But it's like a big TFP shock. But unlike the standard macro models, these TFP shocks have very well-defined dynamics which can be controlled. And these can be controlled by a variety of mechanisms: vaccinations, quarantine, isolation, health capacity. This is stuff which I had worked on myself. So I knew that, what are the kind of things which we should be worrying about, and what are the potential impacts which would come into play. Having higher capital can be a problem. And we have seen this in the case of the COVID pandemic, when OECD countries were the most hardest hit. Role of urban density, pollution, all of these can have negative impacts. I think so. This is the case in Lombardy as well, where people study the effect of pollution on mortality. There was a feeling that OECD countries have higher health expenditures, but so would be okay in terms of dealing with the pandemic. But my understanding from my earlier work was that actually OECD countries would be much worse hit because they had no capacity to deal with infectious diseases. Most of the health system is geared towards dealing with diseases of aging rather than infectious diseases. unlike the Pacific Rim countries, which have had a history of dealing with pandemics, and they have systems they could activate. The role of disease externality, that is not taking into account how your own actions affect the transmission, that will necessitate user mandates such as mask wearing or uh, restrictions on mobility, restrictions on interaction, because people do not take into account the effect on others. There'll be non-linearities in dynamics, as the economic theorist is interested in that, but there'll also be asymmetric impacts and inequality. You may have the health effects are correlated with your income levels. The incentives of someone of a low income to control the disease is very different from someone with a high income. And this has basically to do with how you discount your expected returns from labor. The policy response is endogenous. We don't, a lot of the debate is that we should do this. Why isn't country A doing this? Why is country B doing this? But the policy response depends on your particular economic circumstances. It depends on your objective function. So tracking what is the effect of the severity of the lockdown on economic outcomes is misleading, because the policy is being set in response to the thing which you're interested in, that is the disease itself. And it will affect investment in physical human capital and have growth effects. Now, as we know, there has been a large work which has come out in the economics literature, what I'll call COVID economics. And I'll just give some examples on which I think are different ways which are interesting for non-economists, because non-economists do not think of the problems in this way. So one of the issues which was very important was whether schools should be opened or closed. And we know that from other other infectious diseases like influenza, schools are a major source of transmission of influenza. So we knew that schools could be big transmitters of COVID as well. So the question is, if we shut down schools, the kids have to be at home. It has implications for the parents. It may control infections, but it has effects on the functioning of the economy. So should we shut schools or not? The epidemiology and the public health literature was uninformative, because people were looking, if you look at what is happening in a given country, all the schools are pretty much shut. So you can't really figure out what is the effect. But economists are very good in teasing out these effects. So for example, there's this paper by Chernozukov and co-authors which use a dynamic panel in the US by tracking movement of people based on school closures. They also use the fact that the schools in the US are being closed and opened at the county level. There's no national policy. That variation, as well as movement of people, is helps them figure out what is the effect of closing or opening a school as well as a university. Paper.
Aditya, maybe it'd be interesting if you told us a little bit about what they found.
Oh, so they do find that opening of schools has increase in infections. The percentage I cannot remember, but it's like 5 to 7% increase in infections. They also find that there is an increase in mortality related to opening of schools. This is using data from 2020 when vaccinations were not in place. When we go to 2021, when increasing number of schools are being open, people are vaccinated and schools are being opened, we do find that schools are still transmitting infections, but it's not showing up as an effect in mortality. But at 2020 data, we do find effects in both mortality and infections. The mortality effect sort of goes, it decreases. So if we come to end of 2021 and early 2020, in the Omicron variants, the schools are a big transmitter of infections. We can see that because, at least in the UK data, infections amongst the young, the people below the age of 13 who are not vaccinated, really spikes up. And again, if one studies epidemiology models, transmission within the household is a big driver of infections. So if once you have a child, the kid goes to school, gets some sniffle, and then everyone at home is also infected. Similarly, for the case of COVID, the children may be asymptomatic, but it was not the case for older people in the household. Amodio et al. Use a different way of trying to get the effect out, and they looked at the national referendum and which school was used as a place of voting in Palermo. They have the data. So if the school was used as a place of voting, then it was closed for a few days. And using this variation, they can get an effect of school closure and opening, which otherwise for non-economists is very difficult to pin down. So we have a variety of different ways. I'll not talk about each of them. This is stuff which, as economists, we are good at doing. So one of the big questions for us in the committee was, what can we learn from the experience of other countries? The big problem is that if I compare what's happening in UK with a set of comparators, so let's say UK, France, Germany, Italy, Spain, Portugal, maybe the Scandinavian countries, which we think are similar in some ways to UK. Maybe they can tell us something, but we know that there's so much variation in the institutions across the countries and the policies in different countries that what we can get out is more limited. And I think some of the work being done in the American data was very useful because you have a variation. The country is largely, you can say, is the same country, but you have a big variation at county level in terms of what were the mandates in terms of mask wearing, school closures, movement, etc. So that variation can get us a lot of information out, which for non-economists is not something that they really fully appreciated. And the last one, I'll say something about RCTs. So one of the big issues was, how effective is mask wearing? And we have all these studies in the science literature that if you wear a mask, then how you wear the mask is very important. Yeah, it is. And is your nose covered? Is there an airflow coming out from the sides? When you sneeze, there is a flow behind you, how far it goes, etc., etc. So those studies didn't give us a very conclusive view on how effective is mask wearing. There was a study RCT done in Bangladesh, where they had different people wear different masks. And it was very clear that people wore what mask one wore affected the outcome. Forget how people are wearing the mask, because everyone is not wearing the mask in the perfect way. And if you wear a mask, makes a big difference in preventing infection and severe effects, as well as what mask you wear affects infection and outcomes. But a person in the if you ask someone in airborne transmission, that's not the way they'll think about it. They will have someone wear mask and see the airflow of the particles. So I think this is something that economists can do very well, but I'm not sure that we eventually had as big as an impact as we could have had. Okay, so the question is that why didn't economists have enough of an impact? First of all, until COVID, not many economists had thought seriously about epidemiology. There were a few, but there were very few. A lot of the work that was done was not at a detailed enough level to guide practical policy making. So let's examine this recent paper, which is not done by economists. There's one health economist who was also on my panel, but this paper would never get published in an economics journal. So what do? They have a detailed epidemiology model with many groups. And then they have industry level classification, 63 industries for UK. They have infections level at each of these 63 industry level. They use an input-output analysis, which most of us would now not do. But at least in the short run, they can ask the question that, what happens if I shut down one industry? Through the input-output model, I can see the effect on GDP. But I also know that the way the transmission is going to work, it's going to affect transmission. So if I want to have a policy of, I have to do a lockdown, do I do a blanket lockdown by shutting down everything which is non-essential? Or do I allow certain industries to operate? And from the input-output tables, we can also figure out the contribution, the value added. So there may be industries where transmission is not very high, but actually have high value added. We may let them operate. There may be industries which have low value added, but of high transmission. So for example, take the case of the hospitality industry. 2020, there was this big problem that the country was in lockdown for 3 or 4 months. The hospitality industry had received almost no takeout food, which was also a bit restricted. So the UK government came up with a policy, the Treasury came out with a policy of eat out to help out, where meals would be subsidized by the Treasury, not on weekends, but I think so Monday to Thursday, each meal was subsidized to £10. I think it was £10. So a lot of people started going out to eat. Now, if you think about it, eating in restaurants were a major source of transmission. And there's a paper which shows that this led to big, it's coming out of the Economic Journal, which shows that this led to big increases in infections, but not a big increase in value added in GDP. So the kind of detailed modeling which we need to think about setting policies, most economists, we don't do it enough. There is also this problem that publishing patterns in leading economic journals are such that things don't get published in real time. There's a lot of work which was there, but to convince policymakers that this is something we should act on, they would ask, is this published in a refereed journal? And a lot of stuff has not been published 2 years since it was written. So it's very difficult to convince them that we have these results. They'll say, but is it published? Is it peer reviewed? And the answer would be no. And this is related to the long delays in the review process. Clearly, the economic profession did a great job. I mean, the papers being published in the COVID economics and the blogs, the Vox EU blogs are really very good. At least to me, they were very informative, and I would pass them on. NBR papers, IZA papers, and other work, I would pass it on. But then the question would be: is it peer reviewed? Is it published in an academic journal? Economics observatory set up by RES, Royal Economic Society, but eventually it morphed into thinking about other problems rather than just COVID. A lot of special issues and symposia were announced. I edited a special issue of Journal of Mathecon. We worked very quickly. We gave a deadline of submission in mid-2020, and the issue was finalized in about 4 months, because we gave referees 1 month to referee, authors about 4 to 6 weeks, and then the decision was made within another 2 to 4 weeks. But that is not always the case. Other journals, this was one of the early ones, special issues. Journal of Public Economics, a lot of papers in COVID economics, which I had looked at, were published in the Journal of Public Economics series. JET had a deadline in 2021, but so far only 4 papers have been published. A paper which I'm writing for another journal is still 2 years have passed. It's still in its 3rd round of revision. So if we want to make an impact, we need to think hard in terms of a crisis. When can we get things done in real time?
So if I could put in a plug for my own journal, the European Economic Review, we followed a different model. Rather than a special issue, we created a special section.
Yes.
We assigned editors specialized to COVID.
Yeah.
And this was a fast track process. So we tried to maintain a standard, but to provide a turnaround time that was a sort of order of magnitude less than the usual turnaround time. But rather than facing an artificial deadline, basically when a paper was accepted, it would go in the journal, and there would be a special section of the journal demarcated. I thought this was a better model than the special issue model.
No, I think so.
One special issue, and then there's a deadline. It's actually still rolling, although we no longer provide the priority that we used to, right? Because we developed a lot of expertise in it. Yeah.
No, I think so. I think so. That is a very good model. I haven't done. Yes, I think so. That's a very good model. Like the Journal of Public Economics also seem to be following a similar kind of model. But yeah, that model is a good one. I think so. It's something that other journals should think about when we are in a time of crisis, such as this one, how to get stuff published in real time so that policymakers, advisors can go to the Prime Minister and say, this is, these are the latest results, rather than result in a working paper. So this is my last slide. I know I've taken a lot of time. So just looking ahead, you know, when we do research, we have to also think about what is the audience which we're writing for. In the case of COVID, as I made clear earlier on, a lot of the policymakers were non-economists. They don't look at economics journals. They don't look at COVID economics. They don't look at EER, Journal of Public or Journal of Math Econ. So if you want to influence policy, we have to think, are we writing for a wider audience than just economists? Some of the work which I cited earlier, like the paper of Cherner-Zukov was published in PNAS. There was a paper on mass which was published in Science. And a lot of people who would not follow the economic literature would look at it straight away. And this is something we should think about when we write in the time of crises or public health crises, such as this one. This issue of timely response of journals to new ideas, not only in terms of fast tracking work, but in terms of some of the thinking, which is, maybe things which are not very important, which may not be important. So I remember I presented one of my papers on infectious diseases many years ago, and an economist whom I really highly respect, also Nobel Prize winner, said, "You're wasting your time writing about infectious diseases. This is something of the past. It doesn't really, it's not really important for economists to study, because I'd got interested in it when I went to Singapore in 2003, just at the aftermath of SARS, and I saw the devastation, long-lasting devastation it had on the region, and scares of avian flu, etc. I mean, none of them turned out to be very serious, nothing like what we've seen in COVID, but they really depressed the region for a long period of time. And I realized that the models epidemiologists use are models which we can also integrate in our work, which a lot of people are also doing. But getting that stuff published was a very hard process, because people would say, yeah, okay, maybe it's not something we should be interested in. So I think so that we should be open to more, newer ideas than my experience has been. I think so. The other thing which I'd want to say is that, my experience is that a lot of policymakers, most of policymakers are not PhD level. Most of them have no PhD in economics. Some of the civil servants I worked with did have PhDs in economics, and they understood the latest work. But a lot of the analysts had studied economics at the undergraduate or master's level. So if we are not teaching them the latest tools and techniques, then we should think that these people will be the people setting policies few years in line, but they've not been exposed to the latest research at the time when they were students. Forget what happens 10 or 15 years down the line. I think so for other disciplines, we don't baby down the subject. If you teach maths, you just do with the maths or physics you need to do at undergraduate level. But in economics, often we somehow feel that it's too difficult for students, and we don't teach them closer to the frontier than we should do that. I think so that that's something to think about, because these are people who would be perhaps politicians, policymakers, analysts 10 or 15 years down the line. I think so. I would like to stop at this point and take any questions you may have.
Well, I have a number of questions, but I've already
Yes.
asked questions. I'm also supposed to be moderator, so I'm going to give other people a chance to go first. Actually, Adelaide, I noticed that your train seems to keep dropping the connection, and that you seem to be on now. So if you want to ask a question, I'm going to give you first shot, if you can hear me. I'm not hearing from her. Okay, so would anybody else, just I think there's a few of us, you could just unmute if you'd like to ask a question. Oh, she's going to ask her question in the chat. Hold on, because her connection is bad. That's what I was worried about. Okay, I'll read the question when it comes. Let me see while she's doing that if somebody else would like to ask a question. Vincenzo usually likes to go last. Weiwei, Carlos, Junzi, any of you guys would like to go? All right, then I'll call on myself. I don't see so calling on myself. So one of the things that I did not see in all these organizational charts was any group that was tasked with sort of cost benefit analysis. And you mentioned later this paper of Ha and others that basically was doing cost benefit analysis. And you mentioned as well, this is something that you really get published in Economics journal. And to me, in a sense, that's as it should be. I don't know that Economics journal should be in the business of publishing cost benefit analysis. But what strikes me as odd is that the government would not bring together experts for the purpose of doing this kind of cost benefit analysis. That is, why would the government not be commissioning somebody like Ha and this group to come in and do this analysis, because it's very important? And in all the organization I saw, there seems to be no institutional element of that, and I think that's a bit concerning to me.
Yes. No, I think so, you're absolutely right. I think so. That's something which I found is that at least in UK, there was no commission study, as far as I'm aware of, which did that analysis. I think so. The ones for Denmark and Norway, I think so, they did have elements of that cost and benefit analysis. The Norwegian study certainly was commissioned to look at that, and how exactly do you value a life. The Danish one also talked about more general impacts. I can't read Danish, but I've
Right.
spoken to the Torben about it. And similarly, I spoke to Steiner Holden about it as well, but I can't read the report. But these were the concerns which were there. But it was I think so. The problem really is that a lot of people feel they have studied economics and they understand economics.
Right.
Yeah, I mean, a lot of policymakers in UK have a PPE from Oxford, and they feel they know in all there is to know about economics.
Right.
And that's where I talk about the educational aspect. A lot of people.
There's actually a related question. Adelaide has written her question. I'll just read it out. Everybody, I think, can see it, but it's actually related to this question. So let me read her question. So she's asking if economic experts in the government have considered the effects of COVID on inequality. I think by which she means how the differential impact on different income groups. So, for example, job interruption is going to affect people in the informal sector quite differently. And I know we saw this in Singapore. I recall that Singapore thought they had things under control, but there was this huge impact in the informal sector that they completely overlooked. People with short-time jobs. And she's asking the extent to which the UK government, these commissions were worried about this. And she's trying to just get an overview of what types of impacts of economic situations the UK government considering, like just GDP, or the differential impact on different groups. And then she's, sort of looking down towards the future, right? And I actually have I'm going to throw something into this because there's a related issue which goes to the education, because in the United States we saw a very differential effect of people who were relatively well-to-do and had kids in private schools, and the less well-to-do had kids in public schools, because the private schools managed the lockdowns much more carefully. So they would lock down for short periods of time, but then they would be opened. And the impact for not so much for high school, but for the lower grades was, I think it had a huge impact, differential impact on different income groups because of different response to the public schools and the private schools. So I'm just giving that as an example of the type of thing perhaps Adley is concerned.
No, certainly this is a major concern, and at least I can say, I kept on saying that there will be differential impacts, and I know the government did but we have to go back to the big picture. Many different people are saying many different things, and then the Prime Minister's office is listening to different voices. Now, what we are saying, how it eventually churns out as policy, is something else. Clearly, there was a recognition that it would have differential impacts, and it was very clear that it was tracked very intensively in UK, the differential impacts by ethnicity, we didn't really know the income of people who died for obvious confidential reason, but there was many studies which pointed out that the local authorities in UK are classified in terms of some deprivation indices. And clearly, the more deprived areas had higher incidence, higher mortality than less deprived areas. So this was certainly something which was being flagged out intensively to the government. It was there in the medical journals as well, like British Medical Journal had papers on it. Policy groups were doing writing papers pointing it out. The Office of National Statistics, ONS, which provided brilliant data, would track it down. So this information was there. People were clearly aware of it. The real issue is that, what is the constituency of the government? Whom is it responding to?
So I will indicate that in the United States, although it was very controversial, there was a period at which priority for vaccines was given to deprived areas.
Yes.
There was a lot of debate over whether this was right or not. The areas which had poor areas which had relatively high mortality and incident rates were prioritized in the early period where vaccines were not widely available.
Yes.
So there was awareness among policymakers there,
yes,
both of the issue of deprivation. In this particular instance, there was actually effective action that could be taken with respect to that. We're actually running low on time. I just want to see if Vincenzo or anybody, I know Vincenzo often likes to go last, or anybody else has a question. So let's just see if we have another question for anybody. All right, I think I had one observation that I wanted to make, and you can then have the last word, and that had to do with sort of the economists being organized like public health. So the public health people are very organized and have the WHO, and they have this whole hierarchical scheme and so forth. I feel like economists and social scientists in general, we're more like cats. I don't think we're that easy to organize. We tend to, and even looking at the publications that took place in COVID, there was never any really kind of united effort. It was just everybody out for themselves to write their own papers. And I feel in a crisis like this, that the government could play a good role in organizing, getting as they did in the case of the group that you were involved in, would be a good example. And I don't know whether you guys were involved in this. I noted that the UK was fairly exceptional among countries in not halting vaccines every time somebody died because it might have been a vaccination, as opposed to say Denmark or the United States or France or
Yeah.
Italy. And the theory, this was done by public health officials based on the theory, which is a wrong theory as far as any social scientist can tell, the wrong theory that if you halt the trial, people will be therefore more inclined to take the vaccine because they will trust it more. Whereas
No,
Ziegler
no, I,
says exactly the opposite effect. Um,
I think so. In terms of vaccination, just two things. One is that I was going to talk about this allocation of vaccines and the work of Pathak, Somnis, and Unver in terms of advocating this. It was there in this NASM study also that there should be, which was commissioned, and it said that there should be vaccines allocated for deprived groups. In UK, it wasn't done because there the JCVI came out with saying that it should just go by age, because they said that's the easiest way to implement it, and we want to reduce mortality as fast as we can. This has ethical issues, and but that was what the JCVI's.
Italy did it by age 2. They did it youngest first.
Yeah, but their mandate was to reduce mortality.
Right.
So they just went by oldest to youngest, and the young were not vaccinated because they said the risk to them
Right.
are too little to warrant vaccination. So you had another point. I got myself.
Oh, I was talking about the vaccine halts briefly.
No, the vaccine halts, yes. So it was again clearly UK. One thing I think so, it got 2 or 3 things right. If I want to think about it, one was that they pushed vaccines fast.
Yeah.
They did get very good genomic sequencing, so we knew where exactly the data on testing was very high, and genomic sequence is very high. So people knew what strain was prevalent where, which was not the case for many other countries. Yeah, and I think the European case was a case, there was a politics also involved with the Astrazeneca vaccine, and should Astrazeneca vaccine be given? And there was a spat between EU and AstraZeneca because there was the politics of it. And I think so the way vaccines are accepted in UK generally is much better than European countries because of various histories in terms of how vaccines trials have these controversies have been dealt with in the past. Like in the case of Italy, there was a court, I think so in Ancona many years ago, had said that vaccine has caused this, which has had a big impact on vaccine receptivity, which was never the case in UK. Flu vaccines are given, everyone gets a flu vaccine very quickly. It's every year.
Okay, maybe this is a good point.
May I ask a very naive and nasty question? How do you explain that despite these right things that have been introduced in UK, they have the worst performance in the Western world in terms of mortality?
Yeah, that is a difficult question. The thing is that everything has not been done correctly in UK. Clearly, UK acted very quickly. It's been one of the countries which, vaccination aside, which was rolled out relatively quickly in UK, vaccination aside, the implementation of other interventions has been controversial in the sense that a lot of, from the Prime Minister to a lot of other prominent people, have questioned whether these are necessary. The Prime Minister would not wear a mask. So, if he's not wearing a mask, then what signal is it telling the others? There was a big polarization in terms of who wears a mask and who doesn't wear a mask, which wasn't the case in some countries. US is another country where there's a big polarization, who wears a mask and who doesn't wear a mask. So things which should have been done, there was a national lockdown, but there was no restriction on foreign travel. There was restriction on domestic travel. I couldn't go from my house to my office, but someone could fly in from Italy or from Zambia and come into the country without any restrictions. When there was the first lockdown, there were no restrictions at all in people going in and out of the country, but people in the country were restricted. That was not the case in many other countries. They all shut down borders. UK didn't do it because, again, there were pressure groups saying that, we must keep it going. So I don't think the UK did the whole package very well. There are the issues in terms of, the problems of the health system and so on, but it was also the messaging which was not consistent. It was being undermined consistently through the whole period.
Vincenzo? Okay.
I take note of this explanation. Maybe there is also an economic issue there, is the fact that United Kingdom did not invest in the past in the public health sector enough. So
absolutely,
before the vaccination, the ability to provide cares to people was weak.
I think so. I know David has to go, but I think so. There was also another factor, was that in the initial stages, a lot of money was put in the test and tracking system, billions of pounds, but it was given to contractors, not to the existing health system. There are health and safety officers in the local councils, but they were not a part of this mechanism. So some of the responses were done for some reason by the private sector, not by the existing health service. There was a capacity for testing, but this was not fully utilized, and there were other things set up to do testing. Test and tracking was, largely a failure in terms of, if you think about it, the amount of money that was spent and what was achieved was nothing. So it's also trying to reinvent, first of all, not having invested in the health system, and secondly, actually not utilizing the health system in the most effective way, what is already there. Other countries had these mechanisms, they activated them. I think so, which is not done in UK.
Okay. We could probably continue. This is actually a pretty interesting discussion. I'm sure we could continue this for a while, but let's bring the proceeding to a halt at this point. Aditya, that was really great. Thanks.
Thank you.
And we'll be talking about other things soon, I'm sure. All right.